Good morning and good afternoon, everyone. I would like to first thank you for joining us today. We had a really great turnout in the RSVP, so we're excited to be hosting this webinar today on solving the cardiometabolic puzzle. My name is Lynn Rosetto. I'm a pharmacist. I've been working with Lark for about the past year and a half, and I have about a 25-year history in the PBM and managed care consulting world. And of those 25 years, there's really no better time to be talking about cardiometabolic than today. Before we get into the presentation, I just have one housekeeping issue. I wanted to point out there's a Q&A box at the bottom of the Zoom. We'll be leaving plenty of time at the end of the presentation for some Q&A. So please pop your question in there. We won't be having folks ask the questions live. So pop your question in the Q&A box and we will do our best to get to as many as we can at the end of the presentation. When I first started in healthcare a couple of decades ago, we used to talk about something that we called Syndrome X or metabolic syndrome, which now it's a very outdated term, but it really was meant to refer to what we kind of called a trifecta of conditions that made someone very sick. It was basically hypertension, diabetes, and high cholesterol. And at that point, it was kind of the start of cardiometabolic disease, which is what we refer to today. And that encompasses a lot more than just what was in metabolic syndrome. There's also a term that was really starting to be used about 20 years ago, and that's cardiometabolic risk. And that's something that just started to show up in the scientific literature after metabolic syndrome had sort of made its debut. So here we are 20 years later, and the urgency to address cardiometabolic care and do it in a holistic way because it encompasses just so many problems is at an all-time high, because really the number of patients dealing with this is at an all-time high. I know several of you who are attending this webinar today. I see several familiar names. I don't see any familiar faces, but several familiar names. Many of us have been in the industry for decades, and the best thing I can say is that we've actually watched health decline and care models have become increasingly more fragmented. It's just not working as well as it should or as well as we intended when we got into the healthcare space in the first place. But despite that, I honestly feel that we really are in what I would call a groundbreaking time in healthcare. Right now, we're at a time where we have new therapies, we have new technologies, and new care models that are emerging and kind of coming together at this moment. So today, we're going to explore what to consider when it comes to looking at a holistic and proactive approach to cardiometabolic care. And that's now essential today. It's basically table stakes, and it's transforming the benefits landscape. Joining us today is Matt Gibbs. Matt is very well known in the PBM world and has held extensive leadership positions across the healthcare and pharmacy benefits industry. He is currently the president of Lark, still in his first 90 days, and is focused on scaling the operations of Lark, go-to-market strategy, and driving growth. His career has been focused on transformation and transparency at major healthcare organizations. Prior to Lark, he was the chief pharmacy officer at Blue Shield of California, where he led the launch of their Pharmacy Care Reimagined initiative. He also served as president of Capital RX, where he led the operations, clinical services, and government programs. And he even provided testimony on PBM transparency to the US Senate, which was quite impressive. Go ahead and Google that when we're done. He's also held senior roles at EnvisionRx, Anthem, Medco, and Walgreens. He brings a wealth of insights into how pharmacy, policy, and innovation intersect. And I always learn something when I speak with him. So I'm excited to hear his perspective today and hope you are too. Also joining us is Amber Miranda from WTW. Amber is a seasoned healthcare executive with nearly 30 years of experience across the pharmacy and healthcare landscape. Amber brings very deep expertise in the pharmacy benefit strategy space, clinical and specialty management, and emerging healthcare trends. She's advised a wide range of clients, from employers to hospital systems to public sector plans, on how to manage cost, quality, and access in pharmacy care. She joined WTW in 2024 after leading client service and operations at CapRx, and previously spent over a decade at Express Scripts. Earlier in her career, she also worked in global drug development at Eli Lilly and also has experience in retail and hospital pharmacy settings. Amber brings one of those rare full spectrum views of the pharmacy industry, having been on both sides of the table, and we're thrilled to have her today as one of our panelists. All right, well, let's get into it. So this slide really is just setting the stage by illustrating why this current moment in cardiometabolic care is challenging, but I like to look at the glass half full. It's also full of opportunity. What we're experiencing now in the healthcare space is we have a bunch of puzzle pieces that just haven't fully come together quite yet. And when it comes to cardiometabolic, it's really driven by four core forces. We're seeing rising obesity rates, growing demand for GLP-1 medications, and an increasing burden of chronic disease. And there's escalating costs that are tied to all of that. On the right-hand side, the data is telling us just how urgent this has really become. 40% of employers now have obesity as a top 5 condition of concern. Now, when I was looking at benefit reviews over the last couple of decades, GLP-1s came on the scene for diabetes and started showing up in top drug lists over a decade ago, but obesity wasn't even on the radar related to cost. It was never recognized or really even talked about by clients of any size until recently when the GLP-1s grew in popularity. Semaglutide alone is projected to reach $157 billion in sales by 2030. Now, that's a massive number. And just to put some relativity around it, I know a lot of people on this webinar today travel a lot. That would pay to completely revamp all of the airports in the United States that we commonly pass through. So this is a massive problem and it's a massive number. We're seeing major productivity losses each year just due to cardiometabolic risk factors, and a majority of large employers, almost 70%, are worried that based on their interactions with their members, that all of these siloed care models are just compounding the problem. It's confusing for members, and it's really hard on providers to have what I would say 10 different solutions for 10 different problems that are actually all related to one thing, which is cardiometabolic disease. So all of these different pieces point to the same conclusion. We need to have integrated, data-supported, and forward-looking, because of all of these new indications, particularly related to just this one drug class, that address cardiometabolic care holistically, and that pulls all of these pieces together in a way that's easy to access for plan sponsors, for members, and for doctors. And the big question is that too much to ask? Well, in today's world, we do finally have some tools to do something about it. As we've been in this business, we've all witnessed major advances in digital health and AI, and obviously pharmacotherapy with drugs like GLP-1s. And it really has created this very unique moment where it should be easier than ever to deliver care that is comprehensive and truly personalized. So this that we're talking about today, it's not just about treating a disease with a particular name and just leaving it to the doctors. We have to, as healthcare professionals and benefits professionals, rethink our approach, because clearly it hasn't worked fully up to this point. And we need to be looking at how do we help our patients and members, starting with prevention, which should actually come before the doctor, keeping them engaged and interested with compelling information, and finally, long-term management, including when we're successful with helping a patient to reach their goals. So several parts of that can and should be done without needing the intervention of physicians. So that's a major shift to how we approach healthcare when I left pharmacy school. And that's really the shift that we'll be talking about today. So Matt, I'm going to start with you. You've led pharmacy services at PBMs and health plans over the course of your career. So from your perspective, how do you see the roles of health plans and PBMs as how they've shifted in managing cardiometabolic care over the past couple of years as this demand for GLP-1s has exploded?
I'm going to get to that, but I do have to address that my airport is O'Hare, and there's no way 157 billion would make that place. Anyway, I'm totally kidding. It was an interesting fact. No, but all kidding aside, I've been a PBM guy most of my career, and have always been a little envious of what I thought health plans had more control and oversight of, because at the end of the day, they're the ones that have a lot of the HEDIS measures, or have the integrated Medicare star plans where they have to have star ratings. So the quality focus is directly tied to, better reimbursement payments. If there's value-based contracts, it has more meaning. And in PBM, it's sort of not really part of the ethos. And you can even look back 15 years ago, none of these PBMs are around anymore, but they had partners with, companies like Healthways and Matria, and they didn't really it never really worked out. It just didn't make a lot of sense why a PBM who has this kind of siloed information on drug claims, they can get medical claims, but there's usually a pretty big lag on it. There's a lot of hygiene that has to go on that, but it just really didn't put them in the best place to be doing that outreach and case management work when they're not the ones, owning the physician network, the providers, the hospitals, the clinics, everything else. So the biggest shift has really been that the tables have completely turned, and it's really done by one medication class, in my opinion, and that's the GLP-1s. And I always say you can't have a pharmacy conference or presentation without saying GLP-1 anymore, and I think that's really because they're about 10 to 12% of the drug expenditures now for any given employer, and you can see that even with diabetes coverage alone sometimes. So what that has done is it's now shifted and put PBMs who typically, 70% of the time, they're managing the drug side of the benefit. The health plans may not even have visibility into it. They, in general, don't have the ability to intake claims as efficiently. They can, and utilize that with case managers if they want, but they may not know utilization management rules. They won't know formulary status if those changes are on demand. So a lot of things that are taken for granted. So we've seen the shift where now employers and health plans that utilize a PBM are asking the PBM, what can you do to help me manage this category? And you can't use regular kind of PBM rebate management approaches in this class. It just doesn't do it. You have to look at very, I would say, I don't want to use the word aggressive, but I would say integrated and efficient ways of creating utilization management around these products. And we'll get around why some of that is important, because lots of people discontinue. About 65% of people discontinue a GLP-1 for weight loss. About 47% of people discontinue when they have diabetes for a GLP-1. So massive amount of waste. So you really have to approach this very differently in terms of managing this category. And this slide, what this shows is, and I can, I've some issues with this, but it's sort of like I'm considering everything we're showing here. It's a work in progress. It's art, not science. I have to take my analytic pharmacist hat off and say, this wasn't a 10-year study meta-analysis with a peer group. We can't do that because it's happening real time. But this is a year snapshot that basically says, if you're using GLP-1s over a year, plus the medical expenditures, the cost went up about $7,155 per patient. If you didn't do anything or you didn't have GLP-1s, it went up $22. Now, do I think a year is remotely fair to be measuring these clinical outcomes? No way. But it is an early kind of indicator that is the wastage a big piece. So if you're 65% of people walking away, that's just lost cost. I mean, and you get no benefit from it. So again, I don't believe all is lost. I believe there is intrinsic, very good value in these drugs. And a year snapshot is not fair, but we'll continue to see as we go farther out. Are there going to be cardiovascular benefits and other things? But that's the big shift, is health plan to PBM kind of doing more of that. I want to say patient management, case management, because of these drugs have driven that.
So obviously these GLP-1 cost pressures is like one of the biggest pressures that plan sponsors are dealing with today. But what would you say are some of the other cost pressures related to cardiometabolic care that they're facing that kind of go beyond the GLP-1 space?
Yeah, I mean, these are kind of tales as old as time, right? We keep reducing, A1C thresholds. Now there's like pre-diabetics, and so it's how early do you need to catch people, and are people even, if you have an A1C of 4.9, are you actually going to the doctor and talking about it? I don't know if I would. I probably should be, but it's that kind of thing. Is that a lot of the guidelines have moved so far. You can look at lipids. I think they want LDLs like around 70 or something now, and it's sort of like, well, when you and I were in school, it was like you got to 100, you were happy. So a lot of these guidelines are important, but I think they've created, in my clinical opinion, if I still have one, is they've created this kind of like, well, how am I supposed to do that? And you also can create just tons of testing, tons of tons of things that may or may not be needed. And you may lose sight of those that are in a critical case. If they have high triglycerides or their LDLs are, 180, LDLs are 180. There's still a lot of opportunity there. But I think we've created this broad net that we're just expect to catch everybody within our current healthcare system. We couldn't even catch the really high risk ones, let alone opening that higher. So we have to have better solutions to be able to get people in the right programs in the right place and not utilize a physician or nurse's time for all that, because there just isn't enough.
Well, better solutions is really kind of contingent on integrating care. And we've been talking about the care integration story for decades. So what are some of the innovations that you're seeing that kind of make you feel optimistic that the PBMs and the health plans can adapt to deliver this kind of a more connected whole person care approach together versus just transactional care, just, not only just looking at a prescription being adjudicated?
Right. And there's little movements here and there that you start to see where it makes sense. In general, excuse me, I would say I've seen really around where you need medical data, perhaps for prior authorization on the pharmacy side. There's a big delay. There's been big surges in PAs, a lot of it driven by this drug category we're talking about today. And I think it's really created the creative insights, whether it's plugging into EMRs where you can capture some more information real time in your authorization system. If it's leveraging biometric data. So if you're working with a digital support vendor where they're able to transmit any of the biometric data for BMIs or coaching sessions or nutrition or whatever it may be to give the physician, the nurse case manager more of that information, so it isn't always just kind of a self-reported what you can remember experience or a lab value. So I think we tend to migrate towards where is the data set that I can get and integrate versus, where are there other places where maybe members are entering information or where physicians may be doing an AI dictation notes, whatever it is. There's all these other tertiary sources that are outside of like your claims feed that goes to billing. And that's essentially what we use today that may open up an opportunity. And we're starting to see both health plans and PBMs explore those because they need to operationally to keep up with things.
Before I move on to Amber, do you see any differences in the solutions that are being provided by the vertically integrated health plan PBMs versus the smaller standalone PBMs?
Yeah, and I think it's more driven by not the fact that they're big or small. I think it's driven by the fact of, well, maybe this, I think I just contradicted myself. I think it's because of the diversity of their client base. If you're a mid-market PBM, you typically don't have a lot of health plan customers. You likely don't have a Medicare customer. You may. There are very few that do support those. And so you're very employer focused, mid-market. You're going to have a pretty narrow and necessary range of options in really any category, because that's kind of what that market's used to. They're not necessarily asking for things that aren't within the norm of their peer group. But when you get to the larger organizations, there's a couple things. One is big national employers, multi-state health plans supporting. You have different lines of business, Medicare, Medicaid, commercial, exchange, we can go down the list. There have to be a variety of solutions for any category, not necessarily driven clinically, but sometimes driven mainly legislatively in terms of what has to be done. If it's turnaround times, if it's if it's a mandated drug category coverage like we have in Medicare for some areas, all these nuances create that you have to have a different solution in the market. So the more flexible that solution is, that allows a large PBM or mid-market PBM to plug in, have all this data available to them, but pick the components they need to run their program without picking up the phone or sending a fax to a doctor. That's why I think you see the big difference. At the end game, they're just trying to support their customers, and that diversity of that client base really changes what they have to offer.
Thanks, Matt. I really do appreciate that perspective. And you have a really good one coming from both the PBM and the health plan space. So, Amber, it's your turn.
Okay.
So you're a consultant, and when you're sitting with employer clients today, when you do that, what are their biggest concerns that they're bringing to you related to chronic disease care, cardiometabolic, and GLP-1 specifically?
Yeah, so I think it's a really interesting question. And truly over the past 12 to 18 months, as we've seen the explosion, if you will, of GLP use, much of the employer focus has been on cost containment. And so you see a really heavy focus. And the reason that they're being asked that is because at the C levels, they notice that cost and spend is going up. And so their primary concern is, how do we rein in this cost? And the unfortunate answer to that is really just, you achieve cost reduction by limiting access to patients. And so what we find is that up until this point, you end up with a lot of employers in the situation that the state of North Carolina, as indicated on the slide, found themselves, where they just had to either reduce or remove coverage for GLP-1s for weight loss. And that's not really a great way to answer the clinical problem that you're trying to address by just removing coverage. And so what you've seen maybe over the past 6 months or so is some of that conversation is changing to where employers are really starting to say, we don't have an appetite for that. We don't have an appetite to really restrict coverage or not have coverage at all. And so we need something else. And they find themselves in this sticky place of saying, well, what options are there that fit our specific needs? And so that's really where I see the evolution. We're in that period right now. The other thing that's interesting is you see a lot of employers doing a range of things. And so in as much as you've got people reducing coverage, I'm also aware of a client that removed coverage for GLP-1s for diabetes as well. That's just the financial decision they had to make. And that's also not ideal. But more and more clients are doing something in between. And that's where having solutions in the market that give that flexibility and integration at a client level, and not just for the largest employers, but employers up and down the market range, is going to be the most effective way to help people achieve their goals for their plan.
So I think that everyone would agree. We continue to see these plan sponsors considering excluding coverage, restricting coverage. But from their perspective, you said, let's try to find a solution in between. What are you seeing as some of the most important aspects for a cardiometabolic care program to actually have? Like, what are some of the non-negotiables from the plan sponsor
Yes.
eyes?
So I think it touches on some of the things that Matt talked about as well, is really flexibility, being able to integrate and have access to data, removing administrative ease for themselves. There's a lot of concern in the market just around point solution fatigue. You addressed it as well. You have 10 indications or 10 things you're trying to address, and I have 10 apps, and none of them talk to each other. It's inefficient, inconsistent. It creates a lot of complexity in a system that's already complex. And so I think those things are paramount, but also employers are really looking for their members to have engagement, simplicity, language capabilities beyond English. A lot of multilingual employers, and there's a huge need to be able to address that. And for these members and these patients that they're trying to serve, to really have options, choices, personalization for their own care as well, and not just a one size fits all approach. And so it's not a very specific answer about what's not negotiable, but I think it's getting to what we're talking about today, is that it needs to be nimble, simple, within a workflow or in your daily workflow. If you're the patient, it has to fit within your daily lifestyle or it's not going to work out. And so solutions that bring those types of options for both employers and the members that they serve are what is going to be a must have in this go forward.
Well, point solution fatigue is real. My guess is that we're going to see an ICD-9 code for that one of these days soon. But what would you say besides that, that your clients are most frustrated about when it comes to, well, we can say GLP-1 management strategies or cardiometabolic more broadly?
Yeah. So I will say that lack of flexibility and choice is a huge frustration. Often employers have ideas about how they think a solution or a strategy would fit into their own corporate strategy, healthcare strategy, or desires, and their PBMs or whoever they are leveraging to deliver the solutions just aren't flexible. They can't integrate, there are formulary restrictions, they're not able to coordinate across their healthcare ecosystem. Those are some of the biggest frustrations. The other thing I think that employers struggle with is how to evaluate return on investment. I think as clinicians, we all understand that the fallacy of future medical savings is real. You know, a lot of data out there talking about, hey, you'll save money in the future, but nobody ever circles back around to talk about what that actually is. And there's a lot more data in the market that actually shows it's a fallacy, that doesn't really exist. And so helping clients to be able to wrap their arms around how is their money being spent and is it money well spent, that gets termed ROI, and they have to be able to show that to their C-suite. But having consultants, partners, solution partners, to enable them to wrap the language around that in order to continue to bring these things to their benefit is something that will be helpful in the market. But it's something that is confusing and frustrating for them. And then lastly, what I would say about where their confusion or frustration lies is right now it seems very linear. It's if we want to reduce costs, you have to not cover. And what's available in the marketplace doesn't fit my needs. So isn't there anything else? And often what we find as consultants is there's not a lot else yet. But with the advent and integration of AI, other flexibility, modern tech stacks on a lot of the newer players in the market, those things enable the something else that I think clients really need and desire.
So, it's really hard to measure everything that goes into ROI, obviously, and there's those intangibles as well. So I want to talk a little bit about productivity and workforce retention, which is seems to be coming up in conversations that I'm having. And are you seeing a shift in how your employers are thinking about that when it comes to their benefit plan decisions and how they're managing GLP-1s?
So the short answer is yes, but I think it's almost newer. Historically, I wouldn't say too many clients or employers are talking about lost productivity or absenteeism. I'd argue that they should be, but the gateway here is talent recruiting and talent retention. And that focus really leads into the other components about productivity and absenteeism is how do you retain the talent that's there? Well, they have to feel good and want to be at work and be productive while they're at work and not battling the healthcare system. And so those things are tied. And I will say employers are starting to understand that better. And I think it's also because there are better tools for managing those things. And so they have the data they need to know that, hey, productivity, absenteeism is a problem. It's really easy to look at turnover rates and recruiting talent. Those are a little easier to get to. But I would say those things are starting to come into the conversation more, and employers are more concerned about what their peers are doing in this space. I've had a lot more questions of that in the last 12 months about in my market segment, what are other people doing? Because I don't want to be out of line, or I want to be ahead of the market, or I'm okay being a little bit behind. And so those parts of the conversation are more present than they have been historically.
All right. Well, I appreciate your perspective, Amber. Thank you. The plan sponsors obviously are driving the needs in this industry too. So appreciate that. I'm going to shift gears now, and I wanted to ask you both a few of the same questions. So let's go on to the next slide. So from each of your perspectives, where do you think most of these solutions for cardiometabolic still fall short when it comes to connecting the full picture of a member's health? And Amber, let's start with you.
Sure. So I think it's something that we've broached already in the conversation, but the biggest piece is being able to connect that care throughout the entire healthcare ecosystem for a person. So at a personalized level, I think a good example of this is where you walk into the doctor's office, even for a primary care visit, and the medical technician asks a barrage of questions, takes all your vitals, does all the things, and then the physician or the nurse practitioner comes in and asks all the same things again. So that's the most basic example. But as you get into more chronic care, I feel like patients are tired of walking into a doctor's office or talking to any provider whatsoever and having to repeat themselves constantly about what's going on. And so having that personalization, not having to repeat yourself, having your providers connected and knowing what's happening with you, or even the ability to share that in an easy way with your providers is really necessary. And that's one big piece that's missing or has been missing, that we're in an inflection point where those things are starting to happen a little bit more.
Matt, what are your opinions? Do you agree with that, or do you have anything to add to where most are falling short still?
No, I agree with that. I would add that, and this dovetails on that repetition of self-reported data that is relied on as kind of the entry point to our healthcare system. Is just flawed from that point on. And what's kind of sad is we have amazing technology, whether it's leveraging algorithms or artificial intelligence, whatever it may be, that can handle that's an administrative process, by the way. That is not getting someone's medical history. You're either doing it manually on a chart, so you're not sitting there talking about your mother's or father's diabetes, you're writing it down. This can all be done by AI, gathered and create very good summaries and notes. And I know now physicians are finally charting and doing things with AI in the background, which is proving to be more efficient, effective, and accurate than trying to remember what you did, because usually they don't chart right then. They wait a couple days and they go back and try to remember. So there's this fallacy that, providers, with all the pressure they have, are supposed to be the constant input for the source of truth. It's just not working and it's not reasonable. So let's use technology where we can, not to make clinical decisions, but to clean up all this administrative noise that then will allow people to actually do their jobs. So I'm very excited about it, but you apply that same thing which is where a lot of other coaching, health management platforms have fallen short. At the end of the day, it's a nurse or a coach on the phone in a call center or at home. That has not worked for 30 years. We've got to try something else. And so leveraging technology and AI to support that is where things need to head.
Yep.
So, Matt, I'm going to stick with you here. So it's 2025. Artificial intelligence has been around a long time. People use it every day behind the scenes in their lives. And we still have this issue that you just outlined. So why do you think that today so many solutions still remain fragmented? What's the deal?
Yeah, I mean, I think it comes down to, I think everybody, when they think AI, they think like what you can do on certain apps, within your phone. You can take a picture and have it do a very funny story about it. You can go deep in and say, have it read it like Yoda does. These are all the things that it can entertain us in the AI environment. That's not what it is in healthcare. It's really designed to culminate all this data that you continually either have to self-report, or if there's biometric or lab data, and your doctor has to literally scroll back in their automatic chart notes to look and see what your labs were a year ago to get a side-by-side. That should all be things that could be asked and answered within seconds. And it's really the framework that we were operating on, very slow and old, especially medical claim systems. They're ancient. PBM is not too far behind, although there are a few newer ones. But it's one of these things that until that technology gets closer, all you can do is then support it with other data feeds that can produce that in real time for a physician, for a pharmacist reviewing a PA, whatever it may be. You can use some of these digital point solutions who should be connected to AI to leverage that and give that ancillary source. Will it be integrated in the medical chart? Probably not, because it's too far behind.
So, Amber, I'm going to switch to you and kind of stay on the same type of topic. So, if you had to name the what I would say the missing puzzle piece that most organizations should be prioritizing, what would that be?
To me, that would, to leverage what Matt was just talking about, to me, that would be really strongly evaluating your healthcare partners to understand how forward thinking are they? Are they concerned about their lack of connectivity with others? Are they willing to partner with you on a personalized strategy for your employer and your employees' needs? And really start to look at flexibility and partnership versus these are my vendors. I do what they tell me. And so to me, from an employer point of view, that's the missing piece. and only employers or clients or health plans can really do that. But it has to start with the person buying the services and deciding who their partners are going to be.
And Matt, what about you? What's the missing puzzle piece on the PBM and or health plan side?
I think you kind of have to explore real, I would say, connectivity and value-based outcomes. I think what we have today is a little bit of, lipstick on a pig, to be honest with you. It's all designed to create these, like, again, very provider focused. Did they order this test? Did these do these things? There's not a system out there that couldn't automate everybody over 50 has to get a colonoscopy. Like, that should be so simple and automated. Like, why is a physician having to go in, check a date of birth, and order that test, right? So creating really, really value-based care engines, I think, is what, in automating those, so that those tests and things are just automated, and folks can know they need to go into their chart app or whatever it is and schedule those things. It's just, I think we catch a lot, but the technology's not been leveraged.
Okay, well, let's look ahead a little bit. So we've talked obviously about the problem, about what's missing. And if we think about the future with all of these potential new indications on the table for GLP-1s, and also how GLP-1s and cardiometabolic care, it's changed so much in just 2 years. So Amber, how do you think we're going to be talking about this conversation 18 months from now?
So I think the first thing that I would leave employers with, as well as all the professionals on this call, is the historic approach of hack and slashing your coverage is not going to work in this future environment related to cardiometabolic and GLP-1s, but also longer term as well. How do you get around saying, well, we're not going to cover GLP-1s for Alzheimer's, let's say? That's not going to work. And so how you build your strategies, your coverage, how you focus on patient outcomes, all of those things start now and enable us to leverage them on a go forward basis. And the old restrict with a PA, don't cover it, those things are tools of the past that we probably should leave there.
Okay, what about you, Matt?
No, I mean, I agree. I think we have to leverage, virtual provider networks more, telemedicine. These are all things where they could be doing discrete activities to support. And we've been here before. Like, everyone's freaked out about GLP-1s. What was it? Maybe 8 years ago, Hep C. Everybody was freaking out about that, right? So there's going to be another one. Trust me, there's another one coming. There's another one coming. And I love what Amber said. Using the 50-year-old strategies of PA criteria is not going to cut it. And now we're being forced, or the industry is being forced by the White House to come up with a plan. They were literally told you need to come up with a plan by the end of the year about how you're going to leverage AI and build more efficient processes around PA. So it's just validating, again, what Amber said, those old tools are not going to work.
Okay, well, I really appreciate both of your perspectives. Obviously they seem quite aligned, looking at the perspective of different stakeholders here. And now I wanted to open the floor to some Q&A. So as I said at the beginning, please, if you have any questions, enter them in the Q&A box at the bottom of the Zoom. And I'm going to wait for some to come in here. All right, it looks like we have our first question. And so I'm going to direct this one to you, Amber. How are employers thinking about supporting members after they make the decision to change their GLP-1 coverage? So if they're sounds like they're asking if they're excluding it and they were previously including it for coverage, how are employers supporting their members?
So we've seen a range, everything from we just let you know that it's not covered, good luck, which not really a very patient-friendly approach, to pointing them to some other solutions, other benefits potentially that they have available to them, whether it's fitness, wellness, things of that nature. They've also looked at alternative solutions by which to point them, such as Lilly Cares, Novo Cares, other ways to fund those types of drugs. But I would say largely probably pretty messy still. And there's some room for growth and improvement on how that off ramp is managed, I think.
Okay. And Matt, I'm going to just tack on to this same question for you. On the PBM and health plan side, are you seeing any like what offerings are you seeing outside of within the medication management or PA process?
Yeah, I mean it's quite the gamut. It's like if you've seen one, you've seen one. But from what the latest stats I saw is that only about 15% of employers require any type of behavior management program before going on a GLP-1, which to me is like, what are you doing? Because if you're not learning the basic skill set, which likely you don't have, or you probably would not be on a GLP-1, if you're not teaching that basic skill set, when you go off that medication, you're gaining it back. And so that to me is like an employer just throwing, or a health plan, whoever it is, throwing money down the drain. 50% of, at least more than 50% drop off because of side effects. And then there was no behavior change requirement or just some type of resource to access in terms of coaching. It's just, to me, like that's the American way, right? Fast, quick, but then it backfires, right? That's kind of the way we do things here. But this is one we can't do that on. So to me, that is the biggest with their puzzle piece this year, is you have to have some type of behavior change vehicle. We're seeing some are requiring it in enrollment before they can even get the drug. They have to show they have some reasonable activity. Are you at least going into the app and entering your food diary? Are you at least doing a certain number of exercise or walking per day? Are you weighing yourself? Those are all very, very, very simple things, but if they're not being done, and I'm just being predictive here because I don't have studies, you will not be successful on the drug long term. I do believe that. So that's what we want everybody to be successful, right? So yeah.
Yeah, and I think there's so much data historical over the last 50 years about what happens when you go on and off a fad diet. Mm-hmm. And so drawing the parallel from a fad diet to just on a GLP-1 for weight loss, those things are the same in this context. So being able to draw that for clients and help them understand the importance of that is really paramount for both, whatever vendor partners you're utilizing, but also consultants as well. Yeah, you should be helping your clients.
I'm going to steal that from you, Amber. I like that.
That's fine. Happy to provide that.
All right. Well, I've got another question here. And at first I thought this maybe was a sarcastic or funny question. Amber, I'm going to give this one to you.
Okay.
Shouldn't the FDA guidelines for BMI be enough to sustain financially related to GLP-1s?
Well, I could get on a soapbox actually about how rubbish BMI is as a measure of overall health, because it doesn't take anything into account other than your height and your weight, muscle mass, fitness levels, all of that's out the window. So first of all, BMI is garbage, but it's what we have. And the FDA doesn't do any sort of studies about, hey, if we set it at this level, that is financially sustainable. Also, the FDA doesn't have any authority to tell the pharmaceutical manufacturers how much they could charge. ICER's done a number of studies. There are a number of studies in the market as well about the cost of benefit analysis over the current cost of GLPs for what they provide. And I know nobody's probably shocked to find out that actually GLP-1s are overpriced based on the quality of life that they provide. And so until we balance that scale, there's not really a good answer, but the FDA doesn't take any cost into consideration. Yeah. It's a short version.
All right. Next question, Matt, I'm going to give this one to you. Why not just promote DPP programs?
Well, not everybody that's overweight is pre-diabetic necessarily. In fact, a great number of them aren't, especially younger folks that are overweight. We see a higher percentage of 20 and 30-year-olds, and even teenagers now, unfortunately, in terms of overweight, where DPP is definitely more focused on, really, you do have a lot of people that fall in both buckets. So I would agree you could likely do that. But again, it is a slightly different, you're worried about a lot more on the blood sugar side. You're worried on the carbohydrate side. These are all things that can contribute to advancing in the diabetes, where weight loss is going to be different. And there's also going to be likely dietary restrictions and other things that we see a lot on the weight management side. You have folks say they're gluten-free, or they say they're doing these things. You have to adjust accordingly. or in diabetes, it's going to be or pre-diabetes, it's going to be a different road. So while I agree there is significant overlap, there are nuances that DPP would not work for all people that need weight loss.
Okay. Another question for you, Matt, and in one of the things that you were talking about earlier, you mentioned sometimes things are driven by legislative changes. So what changes would you want to see in the from the government side legislatively related to this to help?
I don't like the blunt instrument that's been used. We're going to negotiate GLP-1 coverage. No, we're not. We're going to force Medicare to cover. No, we're not. That isn't helping anyone, but like how classic political nonsense is that, right? Like it falls in line with everything else that goes on. And, no matter what side of the aisle you sit on, there's these blunt instruments that are used and it's not helping the patient. What I would like to see is that we have, kind of what we talked about, that behavior changes and being in coaching tools and assets and having access to that should be a fundamental part of covering these medications, which are going to hit a lot of state plans, whether it's Medicaid, whether you're somebody that gets a subsidy in the exchange. These are all costs that are going to hit not just the individual, but will hit taxpayers as well. And so why put them on things where, again, we're seeing 65% failure rate, people taking it for a year, where we're seeing weight come back when they haven't learned behavior mod. I just hope that it's more of a holistic and not just, you have to cover at the label, but we know it's going to happen. You have to cover at the label because that's the easy one, but it's going to cost us the most and give us the worst results.
Yeah. Well, behavior mod does encompass obviously many things, a lot of these kind of natural lifestyle changes. So there is a question, how do we promote natural lifestyle changes more? Let's start with you, Matt.
Oh, for me, it's carrots don't work anymore. Carrots work for a good lifestyle change in terms of eating, but they don't work in terms of motivating. So I feel like we need a few more sticks, which means, if you want a GLP-1, show me through whatever coaching app you're using, whatever tactic you're taking, that you can weigh yourself once a week. And I can see that through my digital information. If you're not willing to weigh yourself once a week, you're not going to be successful. Period, full stop. Show me that you can do, 90 to 100 minutes of walking or exercise within a week on average. These are all like little baby steps that, again, should not be impossible for folks to do. I mean, there's exceptions to every rule, right? And I totally get that. But we're not even asking that. We're just throwing a drug on somebody and saying, good luck, sorry, you're nauseous. So that just isn't the way to do this. If we're going to really help people and tackle this long term, there are things we could do to incentivize and say, hey, if you want access to this, which we think is great, we want you to be successful. So you have to do these minimum things, 3 months, I don't know what the period is, and show us that you can do that. And then guess what? You're on. And I think people would be motivated to do it. Right now, it's just like it's the have and the have-nots. Again, kind of what we're used to here. People just get it and there's no repercussions and they go off, they go back on, it costs all this money. And then other people who probably really need it can't get it. So
Yeah.
that to me is how we have to get there.
Yeah. And Amber, related to the kind of promoting natural ways of lifestyle management, have you seen any like innovative or exciting ways that plan sponsors have approached like communicating that or promoting that to their membership?
So I think, yes, I have. And I think it largely comes down to overall corporate personality, right? If those things are baked in at the base pillars of a corporation or of an employer, employees are more likely to join in and be part of those things. And it's because of that sense of community. There's so much data about what people are able to achieve in a sense of community. And so I think the employers that are looking at their constituents, their employees and their families that they serve as longtime pillars of their community that they're building have a lot more success with those types of things. And so I have seen a lot of companies do that. Now, I certainly understand that not every company has the financial ability to do those things, but I've seen a lot of really creative and interesting things where engagement rates are higher than what you'd normally see in the market. Outcomes, people sticking with programs for long term, less drop off even when they're on products. And so I'm seeing that. I don't have great data. There aren't studies peer reviewed, Matt, to your prior point, which is what you'd love to see. They're more anecdotal case studies type scenarios. But more of that, I think, will produce the outcomes long term that clients are looking for.
Okay. And
Yeah.
there's a question in here about the cash pay as well. So we're seeing obviously cash pay from both Lilly and Novo advertising directly to members. It's on television. And
Yeah.
are you having any discussions, Amber, around subsidizing via reimbursement for employee costs when they go to these direct arrangements instead of covering
So,
the benefit?
yes, there is quite a bit of discussion going on in the market about that, and clients looking into the possibility of structuring their benefit as such. I think there are some compliance situations that need to be evaluated. This is where a strong consultant, as well as, ERISA and compliance folks, can help guide clients and employers with how to structure, or if they can structure a benefit in this sort of way. And it's got to do with the definitions of what is a group health plan. And so it's very complex. And I can't do it justice on this call, but I would say, yes, those conversations are happening. If a client was interested in such a thing, highly recommend getting your consultant and their compliance and ERISA experts involved.
All right. Thank you for that.
You're welcome.
Matt, in one of your answers, you were talking about coaching, that coaching should be basically compulsory. What do you think is the best avenue for coaching, or how to get that done?
So this is going to be a weighted response. My belief is I like to see different things, and and I think it has to be a diverse coaching experience because I actually sat in a focus group where folks that have struggled with weight most of their life, they were like, I actually like talking to a computer. They said computer instead of AI. They're like, if I have to talk to another human that tells me to exercise and lose weight again, but give me no real strategies and hands me a pamphlet, I just like going to lose my mind. So it was really a good learning moment that there's a whole swath of folks that have been told the same thing for 20, 30 years, and they like a different medium that they know isn't judging them. So I think having, and I'm not saying that, that live coaches are judging. I mean, it's part of their job, but that's an innate feeling I'm sure that you get. And so I think it's you need a diverse experience where if they can come through an automated or AI where they're able to have those meaningful conversations, get feedback in a non-threatening way, given suggestions in a non-threatening way, and even where that AI can learn how you respond. So the AI can track over time. I suggested this meal and there were 2 pounds of weight loss in the last 2 weeks. So I'm going to do more meals like that because they liked it and they lost weight. That stuff, that continuum cannot be done by a live coach. It just can't. They don't have the ability to call back all that data and slice and dice it that way to give those more meaningful, better results and reinforcement. They're really hard to do in the live environment. Just in the same breath, you need to have those live coaches available because there are moments for sure where you need them. If something clinically escalates or there's severe side effects, if you happen to be on a medication and you need to get connected with either a virtual provider or your own doctor, AI can't help you there. I think it's greatly underestimated how we can leverage that coaching experience to bring more meaningful results for folks.
Matt, I think you just answered this other question too, which is, as a plan sponsor, how can I get over my fear of AI?
I think that's it. I think when you boil it down, people think, oh, it's going to be like the online chat products and how that works. And AI in healthcare, at least for what I've seen, if it's determinative, so it's giving it's giving options for people to select. You can't free form in there. Oh gosh, if I lose another pound, I don't know what I'm going to do, or I'm gaining another pound, I don't know what I'm going to do. It's scripted, but allows you then to interact, and it learns from how you respond in those determinative AI conversations, how best to talk to you, how to address you, what time of day. Like you get a notification at 7 a.m. on my phone, I don't look at it. You get me at 7 at night, I look at it. So guess when I get my notifications, 7 p.m. at night. So those are the little things that just can't happen in a live environment because they got a call list and people. And that just gets really hard to be efficient. So to get over the fear, I would say the only fear people should have is that you are leaving something better for something worse. And I don't believe for a minute that what is done currently for 30 years is better than trying this.
Well, before we wrap up, I'm gonna have one more audience question. I'm gonna ask you both to kind of put your clinical hats back on for this one. So the question is the failure of GLP-1s to improve overall health for non-diabetes obesity due to lack of adherence or lack of efficacy? And if it's the latter, due to lack of efficacy for overall health, is there an argument that GLP-1s should be considered cosmetic in nature with no impact on health?
Oh, interesting. I, having now, I will say this is a weighted answer to Matt's prior point because I actually did a lot of the pivotal trials for the first GLP-1s. Okay. So I will tell you from my clinical hat, it's not a lack of efficacy. More often than not, it's going to be a lack of adherence and consistency and sticking to the formula that works. And the formula that works is not just the drug itself, right? It's all this other behavioral component that goes along with that. And so to me, it's a behavioral um, failure and not an efficacy of the drug failure.
Okay, well, thank you. Matt, did you have something to add to
No,
that?
I agree with that component. The other component I would say is we see in our own data that if in the wild, docs or NPs are prescribing these, they're going to like max dose when you see basically similar results at half dose and fewer side effects. So there's a lot of like just free license going on with these again. So and again, we're learning. So hopefully we'll learn, and we're even learning how to wean people off of these and put them on other anti-obesity medications that aren't controlled substances. So there's a whole bunch of stuff that's going to happen in the next 12 months. But is this a lifestyle thing? I don't think we can any longer ignore that this is a lifestyle thing. This is a problem, and it's contributing to all the other things that are documented medical issues. So, in my belief is that it is a health condition.
Okay, well, Matt, to wrap it up, I'm going to give you, this is my question, so not an audience question. If you could wave your magic wand, we often get asked about our magic wand. What's the one thing that you would change about how our industry and plan sponsors making benefits decisions are handling GLP-1s right now?
I think I have like a fairy tale wand, which would be that everybody eats healthy and we live long, productive, happy lives, and we get to see our great grandchildren. To me, that is like if I could wave a wand and lose all the bad habit, advertising, all the stuff that contributes to our bad decision making go away. That isn't going to happen, even probably with a magic wand. So my more realistic one, I would say, is we've got to stop looking at this as a blunt instrument, coverage, no coverage. We've got to look at it holistically from coaching and health changes to eventually weaning off a medication and everything in between, and having those more fundamental conversations, and being willing to realize this is more art than science right now. And so being able to be flexible that there isn't a peer-reviewed journal. I don't know how well those have served us, to be honest, if you look at our clinical results in this country. So you could argue, yeah, there's guidelines, but nobody's following them. So yeah, that's my hope, is that we're more open to this more spectrum approach to weight management, cardiometabolic.
Okay, well, I think we've reached about time. Matt, Amber, thank you both very much.
Thank you.
This will now conclude our Lark webinar on GLP-1s and the cardiometabolic puzzle. A recording is going to be going out to all of you in the next few days for your double listening pleasure. And if you have any further questions about Lark or the programs that we offer, please feel free to reach out to any of us who you might know on this. If you don't know how to find us, you can always send an email to sales@lark.com. Pretty simple. We'll find the right person to get back to you. We would love to hear from you. And there's more webinars to come. Coming soon in September, we're going to be having a webinar specifically about the potential of and the difference between AI and humans for GLP-1 cost containment. My question is, should it be a partnership or a replacement? So I will actually be co-presenting along with the CEO of Lark. So if not before, I hope to see you there. And thank you for joining us today. Have a great day.
Thanks, everybody.